Great to see all of you. I'm so excited to welcome you to meet Tom Judge and hear his lecture. I was going to tell you a little bit about Tom. It's hard because he's had an amazing career. So this is going to be the short version, but I just wanted to hit on a couple of highlights. So Tom is the founding executive director of Life-Flight of Maine, Life-Flight Foundation. He began his career volunteering for the St. George Volunteer Firefighters and EMS Association, serving as an EMT and paramedic for over 40 years. He introduced the first community paramedicine program in Maine. Tom has an extensive background in emergency medical services and air medicine. He has worked in the private, public, and non-government sectors, designing and implementing emergency care systems nationally and internationally. Tom has served as an air medical and EMS subject matter expert for the Institute of Medicine, the U.S. Government Accountability Office, the National Transportation Safety Board, the state of Maryland following the Trooper 2 crash, as well as serving 5 successive appointments to the Federal National EMS Advisory Council. And I had to cut that list short. That was a highlight. He currently serves on a federal advisory commission to end surprise patient billing. Other current service includes the Board Quality Committee for the Coastal Healthcare Alliance, the Rural Health Transformation Team for the Maine Department of Health and Human Services, and the Rural Health Action Network. He's also done incredible work internationally and has some great stories about some of that work that he's done. His international work includes projects and presentations in Canada, throughout the UK, Ireland, I'll talk about in a moment, Italy, Denmark, France, Czech Republic, Spain, Japan, Australia, and South Africa. He was a 1996 Atlantic Fellow in Public Policy, sponsored by the British Foreign Office, and he worked across the UK with postings at the University of Sheffield, the Scottish National Ambulance Service, the King's Fund, and was a founder ambulance member of the Faculty of Pre-Hospital Care of the Royal College of Surgeons in Edinburgh. I'm going to say something a little bit personal. I hope Tom doesn't mind. We had the opportunity to meet a little while ago and have lunch, and Tom spent some time living in Ireland. And as you know, I was born and partly grew up there. Turns out he's also a tremendous musician. My grandmother was a fiddler. He's a tremendous fiddler as well. And in the Irish tradition, he is a great storyteller too. So I'm looking forward to your story, Tom. Thank you for joining us.
Thank you. Thanks so much for having me. It's an honor to be here. I don't do well behind a podium, so I wanted to just kind of walk through some pieces, and part of this is my starting points in clinical care, and part of this is, where does this go and why is it important? So Karen was a 16 or 7, so these are all the pieces of scarcity when we have a demand resource complete mismatch, and what do we do with that? So Karen was a 16-year-old, lived in our town with 7 friends and 2 cars on a January night, 20 below zero, and the cars were in a drag race, and one of the cars went through a telephone pole, and both cars and all the kids were incredibly hurt. The way that we worked in our little town, who was ever closest would just go to wherever the scene was, and then people coming from the other direction would get the ambulance and whatever else was needed. So I was the first person there. And I ran into Karen laying in the road. She was still alive, she was breathing, she was moaning, but she had clear evidence of an open head wound with brain tissue showing. And I hadn't seen any other kid. And so I covered up with a coat, and I went on to the next kid. And that was really this piece of scarcity, when you have to make that decision. And in the end, 3 out of the 8 died, and 5 out of the 8 we saved. And this was long before Maine had a trauma system, long before Life-Flight, long before lots of things. But it really taught me something about scarcity. I was in Belfast. We did a project in Belfast, Northern Ireland. I was working with one of the paramedics one day, and he said, you know what our real job is? We're the dustbin men of society. Everything that goes wrong ends up at the door of EMS in the emergency care system. Whatever goes wrong in society, it isn't just about illness or injury, it's whatever goes wrong in society, and we have to keep picking this up. We're the dustbin men. We don't get resourced for it. We just have to keep doing more and more. I was in South Africa. We were doing a project. We were in Elizabeth Township, and we kind of had lots of children, and we were asking children about what they wanted to be when they grew up. And here's this little 7-year-old girl, and you asked her, well, what do you want to do when you grow up? What do you want to be? And she just kind of looked at us, and she said, well, but nobody ever promised me a long life. So she had no idea of what a future would be. And this is this mismatch that we run into. And at the pointy end that we work at in resuscitation medicine, we're always in this fight of time, resources, disease, what we can do. We struggle with care at the end of life in this entire country. We struggle at Lifeline with it, that we have people who we're sure are not going to have a long trajectory going forward. But there's nobody else to take care of them. And where they are, there just aren't the resources to say, what we'd really like you to do is move you into palliative care, and for the next 20 hours, the next 8 hours, the next 36, 48 hours, we'll take care of you and your family. But if you're in a little tiny hospital in Maine and there's one doctor and one nurse, we can't take care of someone for 20 hours. That's a high intensity care. So we struggle with that in the United States. We struggle with the cost of poor quality and variation. It is a gigantic problem in medicine, and we struggle with duplication. When we set out, we set out to work in this idea of pillars, and Robert Maxwell was one of the great thinkers of the National Health Service, wrote a paper back in the mid-'80s about how we should assess how healthcare systems work. What's the value? And he said there should be 6 tests. Access, do we improve access to care? Do we do the same for everybody? Is this really, when we spend money, do we actually get an effect? If we're going to spend a resource, can we measure that we got what we set to do with that resource? Are we doing it at the lowest cost possible? Is it economically efficient? What are we going to do with appropriateness of care? Is it the right care at the right moment? And are we willing to change? And we know change in medicine is very hard. When I was in the UK, the Cochrane had done a study about how your doctor will treat your hypertension. And the single best predictor for how your doctor will treat your hypertension was the year that your doctor graduated from medical school. Science is really hard in this. And then to that, we've always added a 7th test of, is the system safe? Well, with all of that as a program, then I got into helicopters, right? So helicopters are very sexy. They're very expensive. It's a very high unit cost of service that may look like it's cost prohibitive. On the other hand, if we think about it carefully, maybe from a system side, maybe it's not cost prohibitive, and maybe it's actually cost efficient. And in time-dependent disease, myocardial infarction, stroke, trauma, how do we look at this kind of piece of maximizing the efficiency across the entire system so that if everybody does exactly what they're supposed to do at the right moment? And in trauma, we have this W statistic, right? So this is HEMS trauma, EMS helicopter trauma. How many measurably lives do we save? Unexpected survivors of the system. And you can see over time that it ranges, and we probably are into the 3 or 4 range in 100 patients. So 3 or 4 at 100 patients, we know we definitely 100% unexpected survivor. Without this resource, without these people, they wouldn't last. And that doesn't sound like a lot, but it adds up, right? So over time. The problem in all of this is when we go into this, that in scene triage criteria, one of the problems is in the professional opinion of the dispatcher, we should send the helicopter. That's not exactly science. It's a professional opinion of someone who may have very limited medical training. And so we've done a lot of work on guidelines and stuff, but we still struggle. That if we look at blunt trauma, we look at the kinds of things that we would say, what are these things we can actually measure going on in a patient, and does that make a difference? But we know that to get 92% sensitivity, we have about 8% positive predictive value. So that's the problem with triage. And we've never, ever, we're just doing all this work in Newfoundland right now, and we're trying to help them understand why they would invest in their medical system. And you're sitting there saying, here's the lives saved, but we know this triage issue is still undetermined. We're going to bring a bunch of physicians from around the world to Miami at the end of June, and this is one of the big topics of the meeting. And then we know that in the efficiencies, how we allocate and how we have technical resources may be more or less effective depending on how we deploy those resources. And as Governor Lamb said, most of our medical miracles in this country are physical failures. And that's a real challenge. So we'll talk a little bit about this. So here's the part where you get to do, you're distraught, you're next door, and the 8-year-old comes in, she just found her 12-year-old sister and 3-month-old sister face down in the pool. Both are not breathing, both are in the bottom of the pool. Volunteer EMS, 25 minutes away. Who are you going to save? Who's going to save the 3-month-old? So we got some votes. You all had to vote. You're here, you're in a medical school, you got to vote on this. You got to actually do something. So 3-month-old. Who wants to say, if I can save one person, I'm saving the 3-month-old? I got 2 votes, I got a few votes. How about the 12-year-old? Okay, so we're going to come back to that because I think that's a very, very interesting question. You're speaking with your 95-year-old mother. She's long-standing mitral valve defect. She's got shortness of breath. Doctor says she could have improved life status if she gets this valve replaced. In addition to her heart failure, she's got recurrent bouts of pneumonia, chronic bronchitis, and she's high risk for anesthesia. And there's going to be a complicated surgery. What should your mom do? How many people say have the surgery and extend the quality of your life? No votes? I'm voting for that. I'm voting for my mom. Come on, you only get one mom. You only get one mom in this world. So, I think that's a piece. So here's another one. You're the member of the legislature's Transportation Committee. Recent bus crash, a close friend comes and says, I want you to introduce a bill to require seat belts on all the school buses in Maine. Costs about $375 to $600 per belt, $5,500 to $7,300 per bus. How many people want to put seat belts in buses? Okay, all right, so we know seat belts in buses. Here's the benefits of this. NHTSA says it's about $23 to $36 million for life saved, and NHTSA says local governments should figure this out. So the feds have said you can figure this out locally, and Texas and California require school bus seatbelts. No one else does. So we're going to come back to seatbelts again. So goals in designing a system, we want to reduce mortality. We want to get unexpected survivors. We want to reduce morbidity, the long-term cost and consequence of disease. And we want to reduce the costs of care. And it's interesting, the Maxwell principles that we set up, no one really listened. People listened to him in the UK. No one listened to him in the US, except for Don Berwick. So Don Berwick listened to Robert Maxwell. He was a disciple of Robert Maxwell. You all know who Don Berwick is? Okay, so Don Berwick is the doctor, probably the living doctor who has saved more lives than any other doctor in the entire world. He's a pediatrician and set up the Institute of Healthcare Improvement and set up the 200,000, which became 600,000, which became 2 Million Lives campaign. If hospitals would only do 5 things, we could prevent 2 million deaths in hospitals, from care in hospitals. So Don Berwick, and so when you look at the Affordable Care Act, the entire Affordable Care Act is written into Maxwell Principles, almost word for word. He was a survivor. So those are things we're trying to do. So from a society, healthcare, right or privilege. How many people believe that healthcare is a right? Good. How many believe it's a privilege? Okay, so it's a mix. It's fine. What is a life worth? And we're going to come back to that. What's the biggest bang for the buck? What do we do? And we're going to come back to that. How much do we spend on kids, adults, and the elderly? How much do we want to spend on those? We're going to come back to that. How much do we spend on acute episodic care? We know that we can pick up a patient, and in an afternoon, we're going to spend north of $700,000 or $800,000, just like that. When I was a paramedic in Bangor, and we used to harvest organs, the planes would start coming in. So the first jet comes in, and they've got the cardiothoracic guys, and the next plane comes in, and they've got the kidney, and liver guys. And the next plane comes in, they've got the eye and the bones and the skin, and the planes would come all day long. When I was in the UK, in Ireland, they had a case in Limerick, a closed head injury, young patient. We're going to harvest the organs, but the only place they could do that was Dublin, long ambulance ride. And they were like, oh, wait a second. We're going to need to convene the health board to vote on whether we should fund this ambulance to take this person to Dublin because it's not in the budget. So those kinds of things, we around here, we just go like that, and we start spending money. It's interesting, one of the things they found with the bombing in Oklahoma City many years ago was one of the single biggest things in unified command is you had to have a finance person there. Because someone's sitting there saying, we need 12 more excavators. We need 25 more dump trucks, and we need them right now. And you have to have someone that's, public official that said, here's the card, spend on it, that we do it. So do we spend little dollars to get big impact, or big dollars per capita to get big impact, and both of them work? We know that spending in this country is really a problem. 4.1 trillion. It's actually come down a little bit in the last couple of years. This was in 2020, at the height of the pandemic. We were spending about 19.7% of GDP. A lot of economists in the world say that if you spend 20% of your GDP on healthcare, you will tank everything. This will become a spin to the bottom, and every single thing in your economy will fall apart. And we're kind of on the edge there. We also know there's a lot of variation. If all hospitals performed the same, we would have a lot less complications. We'd have a lot lower mortalities of things and morbidity from stroke and AMI. We also know that 1 in 4 patients suffer an adverse event in the healthcare system. Iatrogenic, so the cause of their problem was the care that they were receiving. Annual preventable medication, $7 million, $21 million of cost per year. Iatrogenic events are now the 3rd leading cause of death in the United States. So being cared for in a hospital is the 3rd leading cause of death in the United States. There's a huge variation in care, despite the fact that we spend far more money. We spend at least, 5 or 6% more GDP than any other nation in the world. In 1998, we were doing this project in South Africa, and this is what we wrote, and we wrote 3 papers that came out of it. We were saying there's an unprecedented need to control the cost of healthcare. An agenda for change, developing and developed world, indirect constraints. That was 1998. I'm not certain that we've made a lot of progress since then. Health and Human Services, 2022, 1,200 drugs outpaced inflation. the spending on drugs is driven by more expensive prescriptions than more prescriptions. So the price of drugs in the United States, we're not just prescribing more, but we're prescribing more expensive drugs, and that's outpacing the number of prescriptions that physicians write. So that's a real challenge for us. So we know that in all of this, there's a crucible between what's the evidence, what's the public expectation, what are the politics, and as professionals, as clinicians, what are our expectations of how we deal with this? And cost containment is here to stay. And in the end, right now, this is not about physicians anymore. It's not about hospitals. And even it's not about policymakers. It's about how the courts will decide that we're going to practice medicine. That's a very, very big change. There's nowhere else in the world. Other people are struggling with it, but there's nowhere else in the world that really looks to the courts to determine how medicine gets practiced. And if you want to know the entire healthcare economy, spending, everything in healthcare in one slide, this is what it is, right? Promoting price transparency, that's the big thing we're doing. Very small price reductions. Providing competition, the other big thing we're doing, small price reductions. Capping the level of spending, regulating prices paid to providers, which is what happens everywhere else in the world, moderate to large price reductions. So as a country, we've just never, ever grasped the nettle about how to do this. We're doing things at the margins, and we're not making a lot of progress. And obviously, your perspective in all of this changes, right? If you're the user, if you're the clinician, if you're the financial person, if you're society at large, how this gets put together always matters. And we also know neurologically intact survival from out-of-hospital cardiac arrest, we get better and better. It's about 5 to 15%, a little bit higher in some places in the United States. It's about 2 to 11% in the UK. But on television, it's 67%, and most patients are under 50 years old, right? So most people on television that have a cardiac arrest get saved, even though, and that's the expectation. We did a study with Chris Potholm at Bowdoin back in 1987 when I was on the board of EMS, and we wanted to know what people understood about EMS in their communities. And we kind of asked what their expectation was. No one knew who the people that were going to show up at the door were. They didn't know who they were, where they came from, who they worked for, how they get paid, but they believed that they were all paramedics, which in 1987 was not the case, and they trusted them. They're very, very high trust. When I worked in Northern Ireland, you had a fire, the fire engines go, and each engine has a Saracen, has an armored car or tank right behind the fire truck. The EMS service would just go anywhere. One minute we'd be in the Falls, the next minute we'd be in the Shankill. No one bothered us. We didn't even carry portable radios, because a portable radio, people wanted that portable radio. So it was just these expectations and how the public thinks about things is really a bit of a dilemma. So the meat of this is, what do we do about the cost of the prevention of harm, because this is the policy issue, and what do we do about the cost of the intervention for good? So we can do lots of cost effectiveness analysis, cost utility, cost benefit, cost minimization, burden of disease. And when we put these all together, we say, here's the incidence. Health state cost 1, we're going to change, we're going to do an intervention. And health state 2, did we change the quality of life and life expectancy? And we get that from medical literature, we get it from research, we get it from our experience, get it from databases, from trials, all of those things go together. So thinking about this from a ground ambulance versus helicopter, this is how a study might look. So that the total cost of the helicopter minus the total cost of the ground ambulance is the incremental more cost of the helicopter, and then we look at that with qualities and say, where did we get the incremental? So we know the cost, and we can get an effect. And that would be sort of a cost effectiveness study. And in where we live, the value of a life, is this is being done all the time. All the time. Every policymaker has to do this. By law, every federal agency has to do this. They have to do these calculations every time they write a rule. So what's the cost of buying one extra quality life year? And you can sort of look at all these cost effectiveness grids. Pros of this, common language. VSLs and qualities are a common language. We're going to talk about some of the problems. Foundation reflects value. We know how this works. The cons is most people don't understand it very well. We don't know what good value. We haven't agreed on that as a society. We don't know about budget impacts. We're learning more about that. And we choose often to just not pay attention to the data. So that becomes kind of one of the problems. And a fatality versus, is a reduction of how much are you willing to pay. WTP, you'll see this, willing to pay to save 1 in 1,000, 1 in 100,000, 1 in a million lives. How much are we willing to spend to get that effect? That we're going to have an unexpected survivor at the end of that doing things. And if you look at the value of mortality, different way to look at it, but the VMR and VSL sort of micro risks kind of thing, but it's close to the same. The language is the same, and you can have quality adjusted life years, you can have the value of statistical lives, you can have DALYs, disability adjusted life years, you can have life years lost. There's lots of ways that people tease that out, and in the end, they're mostly the same. So the VSLs currently, the EPA VSL runs from $14.4 million to $40.5 million. And they've increased that, and they say they really need to do that because we don't know about cancer. So we're willing to write an environmental regulation that someone will spend $14 to $40.5 million to get one VSL. FDA says the range is 2.1 to 20.7, 11.4 is what their working range. Department of Transportation, injury prevention, road safety, 12.5 million. Homeland Security, Department of Homeland Security, they say 12.5 million. We're going to come back to that. The Consumer Product Safety Commission, they're voting on this right now, and they say for an adult this should be 13.1 million, actually, and for a kid it should be doubled. So we'll write a regulation to save a child, and we're willing to spend $26 million to save that one child. Those are real dollars. Someone has to come up with those real dollars. We also know that the EPA, and this is where it gets into this, that the EPA has gone through a lot of debate. And there's a lot of, if you look up the literature about qualities right now, worldwide, there's a lot of debate. Are we discounting disabled people? Are we discounting the elderly? Are we just discounting vulnerable populations when we look at what are these things? And so the EPA said they're not going to do VSL by the age anymore. And that's why you get these wide variations in what you're willing to spend. So that's a problem with all of these, that how is that going to work and how are we going to do it? So the DHS said, now, 2023, $12.5 million, we're willing to prevent one death. This is Homeland Security. But in 2008, this is a professor from Ohio and another professor down in Australia. They looked at it and said, the upper band, if we prevented 500 terrorist-related deaths a year by all the money we spend on airports and all the money we spend on the Coast Guard and all the money we spend on the NSA, all the money we spend, the FBI tracking all these things, the VSL is about $64 million. But the best case scenario, and how many deaths have we had in this country due to terrorism? A year. It's almost negligible, right? So really what we're doing, if it's our best case is 52 deaths a year, we're spending $617 million. So none of us ever set out to be a terrorist, right? I hope. No one in this room set out to be a terrorist. Well, we're all terrorists every time we go to the airport, right? You take off your shoes, you take off your belt, you go through screening. You're all a terrorist. You didn't even have, after 9/11, you didn't have to take off your shoes until Richard Reed put a bomb in his shoe and tried to set it off on an airplane, and the other passengers stopped him. At which point, then our shoes are all terrorist kinds of things. So it's really, these kinds of things are in the background. We're not thinking about this, but this is the federal budget. All of these pieces are in the federal budget, and when we spend money here, we often don't have money to spend here. And we don't do a good job of really looking at what those trade-offs. Here's an example of science versus politics. So regulating flammability of children's, pajamas, about $1.5 million for VSL. If we required smoke detectors, absolutely required smoke detectors, is about $200,000 for VSL. 30% of children live in residences without smoke detectors. So where would we get a better bang for our buck when we come to policy questions? And that's really the piece. So qualities, you look at this, you live 4 years, you live 5 years, we're going to get some sort of change by treatment and qualities. This is the intervention for good. So value of a statistical life is prevention of harm. The benefit for good is a quality adjusted life year. Over time, we've seen 24,000 to 428. We've seen another study in 2003, 109, 297. King in 2003 said, probably a lot less. The current, that P.J. Newman's sort of the guru of quality values in this country, and they're estimating that somewhere in the $100,000 to $150,000 range. So that we're willing to spend $100,000 to $150,000 to gain one quality adjusted life year. And remember us, Pete was a student here, and now he's one of our medical directors. Remember that we can spend $500,000 just like that. We don't even think it. We can commit to spending $500,000 on behalf of a patient. We do it all the time. We do it almost every day. So it's really, what are all those values? Dialysis, if you looked at 400,000 patients, 129 years and 129,000 in 2009, that would have to be referenced by 1.45 in 2024 dollars range. And this gets into young, healthy person, long-time, unhealthy person, same dialysis, what are we willing to spend? And so that becomes a question of, CMS says we're willing to spend somewhere between $65,000, $488,000, $129,000 on average to get one adjusted life year by dialysis. Cost-effectiveness analysis, it's hard, used for medical conditions. There's got to be sufficient evidence that the intervention, remember the effectiveness test that Maxwell came up with, the beneficial effects outweigh the harmful effects. We see that a lot. We're going to come back to that in a bit. And the intervention is the most cost-effective strategy, right? So we have all kinds of medications that are all kinds of different price range, right? So we can treat our blood pressure for this cost, we can treat our blood pressure for this cost, and we can treat our blood pressure for this cost. And they might work a little bit better, they might not. We can look at AFib, right? And we can treat AFib with heparin, we can treat it with aspirin, we can treat it with a bunch of things, or we can treat it with Eliquis. Eliquis works somewhat better, and it's about 12 or 14 times the cost of other interventions. So what do we do? What's the right thing to do for a patient in doing this? Is it the most cost-effective strategy? So Tammy Tangs in her college, she was at Harvard. I'm not quite sure where she is now. This is a seminal paper, and it really hasn't no one's really gone to do the work to update it. So they looked at 500 life-saving interventions. They looked at road traffic accidents, they looked at construction accidents, they looked at environmental problems, they looked at medical care, they looked at consumer safety products around homes, and they said, here's defined, and they had to have, they reviewed 12 or 1,400 papers to do this that all had good economics behind them, and they came up and said, this is what things are worth. And a 1993 dollar is now $2.16 and $24. So the median that they came up with was $42,000 per life year saved for QALYs. The medical median was around $19,000. Prevention, $48,000 road traffic accidents. Toxin control, $2.8 million. Poison control, $2.8 million. And in 1995, you'd have to adjust all of those up by about 1.4, multiply each one of those up by 1.4, and that's what a QALY is today. So you can see that we're up in the vicinity of 100, 150,000, right, on average kinds of things. Regulate, science versus policy, remember this one? So regulated, these are these trade-offs that we get into of what are we willing to spend, and is it? So here's the thing, is this is kind of adjusted for 2006 dollars. Hypertension, big variable. Cholesterol, big variable. Mammography, we're going to come back to that. TPA for AMI versus a cardiac stent. Hemodialysis, liver transplant, warfarin for stroke. So we can do warfarin versus Eliquis, $8,000 versus about $40,000 or $50,000 per year. 3-vessel cabbage versus TPA, prophylactic AZT after an exposure to HIV, pre-hospital intubation, paramedic ground EMS, helicopter EMS, level 1 trauma center, $2,008, about $84,000 per QALY. Accepted threshold in 2005 was this magic threshold of $40,000 to $50,000. And then of course we've got tick removal with a straw. Doesn't cost a lot, but the value is priceless, right? So the National Institute for Clinical Effectiveness in the UK says they deny there's a threshold, but there is one. And most of the rest of the world is much more transparent and much more specific than we are here. Transparency in medicine in the United States is not, it's pretty opaque. It's opaque in quality, it's opaque in cost, it's a real trauma. They're about 30,000 pounds. If it costs more than 30,000 pounds in the UK, they say spend it on something else. That's not a good value intervention, spend it on something else. Now the current benchmark in the United States, $100,000, $150,000. WHO says we should be willing to spend 3 times the per capita income. So this is all going to be relative to what's the per capita income. You're not going to spend anywhere near as much in the developing world because you don't have anywhere near as big a health budget. So there's different ways to sort of think about this. Here's the current nice guidelines. Cost per call, if it's 20,000 pounds or less, do it. Absolutely, just go ahead and do it. Drug cost effective. If it's 20 to 30,000, we're going to really look at that pretty carefully and say, has that got value? And we might decide to pay for it. If it's more than 30,000, we're just not going to approve it in the NHS. And so this is one of these reasons why, for one of the many multi-reasons, why pharmaceuticals cost way more in the United States than they cost anywhere else. Because everywhere else, price caps these things. We're just not going to buy it. So you either get the price to where we're going to buy it, or we're not going to buy it. So that's a very different way of doing it. The problems with this is that the cost-effective analysis has said all QALYs have equal value, and you could see the Consumer Product Safety Commission is saying, well, wait a second. Children, we should be willing to double the cost for children than we should have for an adult. Spectrum of illness or severity, more, people of vulnerable populations are, are we not willing to spend more on those? So we've got to have public values and you've got to have ethical reasons. So low-value, high-cost sources, and this is why we got into this, right? Because we got into looking at these things because we're a relatively high-cost service with a potentially life-saving intervention that's good for society, but we're spending a lot of money every time that we send a helicopter to somebody. You know, this is a classic example. This is a real case. We had a guy in Edmonds, Maine. He's a flagger. Remember, you're always supposed to go slow in construction zones? Most people don't. So there's a flagger in Edmonds, Maine, and he's standing out there with his flag, you know, say go slow, and someone wings him with their mirror as their truck goes by. So now this guy's laying on the side of the road, and he's at Edmonds, Maine. Anyone know where Edmonds, Maine is? Edmonds, Maine is about halfway between Machias and Calais. You're kind of in the willywags, right? So you can have the rescue come and take you to Calais, and they've got radiology, critical access hospital, they've got radiology, no neuro. They may or may not have an MRI right at the moment. You could take them to Machias, a critical access, a little bigger hospital than Calais, radiology, emergency department in both cases, no neurosurgeons, probably an MRI. Or we can send the helicopter, 100 miles, and we can fly the guy back to the trauma center. Now, if we went out and we flew this guy back to the trauma center, and he's only got a concussion, he's just been clocked, we just spent a lot of money to not really get any effect. But if we're wrong, if he does have a brain injury, and I can't tell on the side of the road, yes or no, if he does have a brain injury and we take him to a little hospital, probably his best case is a lifetime disability. So what do we do? These are hard questions that we have to deal with in medicine every day. We deal with these hard questions every day. Now, our Norwegian colleagues, they've said if we're serious about stroke, we're going to figure that out at the point of need. And in Norway and Australia, Norway's putting a CAT scanner in a helicopter. They already have CAT scanners in their planes. They're putting a CAT scanner in their helicopter because they're like, if we're serious about stroke, at the point of need, we have to figure out, is this an embolus or is this bleed? Because the trajectory and the care is 100% different, right? Our colleagues in London are seeing, can we do this with ultrasound? Our colleagues in Australia have 3 research studies going. One's a CAT scanner in an ambulance. In fact, they just started deploying ambulances with CAT scanners more widely in Australia. But they're also looking at this little scanner that's about a helmet, football helmet. And put you in that, and we can scan your head. And they have another little halo one. I mean, the Norwegians have a CAT scanner they're down to about 275 kilograms. That's still a lot of weight to put in a helicopter. And so, but it's a point of need, you do this. So people are really thinking about what this looks like, and we struggle with it every day in medicine. Institute for Clinical and Economic Review, about $100,000 now. But this was really, we get into the humanistic side, the valuation is certain lives over others. If I'm wheelchair bound, am I worth less? Do I get assigned a lower utility value when we start figuring out the mathematics of this? If the model's course utilitarian is at the same value across lifespans, Consumer Product Safety Commission says no. Is the model potential to rigidify medical options and decision-making, preventing providers from using their judgment? And that's always a challenge. We also know that in this there's trade-offs, right? So we know there's a very big trade-off in prostate screening for men. We spend a lot of money every year in the United States screening prostate for low-risk men. Is there a better way? Can we use AI to figure out who should get screened for prostate, aggressively screened for prostate than that? We know that mammograms under age 50, and it's a debate for every woman. CMS just came out and said high-risk women, most high-risk women with dense breast disease, dense breasts, are in the high risk. They get screened twice a year. One's mammography and one's an MRI. CMS literally just came out and said we're not going to pay for the MRIs anymore. Right, so these are policy decisions with big consequences for people, and we don't really think about those. Statins is another one. Do I take statins or not? How much value am I going to get from a lifetime medication that once we start people on it? So Chris Ham, who is one of the people I worked with in the UK, he said it is the politics of healthcare reform are more important than the science. And it's wrong to assume that simple prescriptions can be developed that people will follow. And that's a real challenge. So all of you going into medicine, this is where you're going to live, work, and breathe. And these are really very, very difficult decisions. So resuscitation medicine, certainly one of the big pieces of this. So here's where this sort of rubber meets the road, and we'll get to questions. So they just did a big study in the US and said, for COVID vaccines, 60% effective vaccine, quality adjusted life year, looking at different things, they looked at everybody, and they said it was $8,200 versus no vaccination. But if we looked at sort of on where this is across the entire population as opposed to the population at risk. The population at risk is somewhat smaller. It's a disease we didn't know about, we're still learning about. That's about 92,000. So it's actually a lot more to spend. And the problem, of course, with COVID vaccines is now we have people that don't want to vaccinate their kids. Like, we don't want any vaccine. We don't want pertussis. We don't want Tdap. We don't want any of these vaccines that we normally give kids. And this has become a very big political problem. We're spending a lot of money. We certainly got an effect. We probably saved 1 million lives in the United States by vaccinating the population, as well as we did, even with a lot of resistance, saved 1 million lives, spent a lot of money. Advanced protective systems for firefighters, right? We're going to spend the cost ratio 2.87. Investment was worth 187. That's a pretty good return on investment over 5 years. But that was that if everything is net present value of 13.6 billion, but the reality is we don't really know if that advanced protective gear for a wildland firefighter actually is going to save their life. Pretty hard to do a randomized controlled trial around that. And so the uncertainty of this is actually, it's more like 19 million and maybe as high as 43 million. So do we buy new fire equipment for wildland firefighters? Do we buy that when we have a big uncertainty of whether or not this works? North Carolina just said, wait a second, you work for the state of North Carolina, you want Wegovy, you're going to pay for it out of pocket. Because the cost we're looking at is going to become $1 billion to the state of North Carolina for those 750,000 people, $1 billion a year. So they're like, we're not going to do it. And of course, the pharmaceutical people say, well, wait a second, why should patients have to decide that they have to demonstrate broad cost savings to the entire healthcare system before they can access a treatment option? That's a hard policy question. That's a hard people. I remember years ago, one of our young people that worked in the healthcare system in Bangor with me, and she wanted IVF. And at that point in time, our health insurance plan, the hospital health insurance plan, didn't fund IVF. And she was heartbroken. She's like, this is the only way we're going to have a kid. And the healthcare system, I work for the healthcare system, and they're not going to support me. You know, and these have become these really hard choices of doing things. And this is, employers are looking at a 5.2% increase in premiums strictly around weight loss drugs. This is a huge impact. So 100 years, we saw that one, I don't know where that went. February 27th, House of Representatives, new legislation, right? Everyone follow this one? We're not going to use QALYs anymore. House of Representatives, 211 to 208 vote, right? So why did that come about? Anyone have any eyes? Yes? So in the Inflation Reduction Act, one of the pieces of the Inflation Reduction Act is for the first time ever, the government is going to negotiate for they're going to pick 10 of the very expensive drugs, and they're going to negotiate with the pharmaceutical companies and say, you're going to give us a price, this is what we're willing to pay for Medicare. We've never done it, pharmaceuticals. So Biden put this through, Congress passed the Inflation Reduction Act, and part of the House turned around instantly and said, we're not going to use qualities anymore to measure pharmaceuticals. Right? So how do we know going forward if we're getting value for healthcare spending? So Protecting Healthcare Act 211 to 208, as stressed is there better be an alternative, right? So this is the practice of medicine being done by the House of Representatives who can't pass a budget and are screaming at each other all day long. They don't have an alternative. They passed this strictly based on politics because the government, for the first time, said, we're going to negotiate drug prices. And we're going to negotiate. We're not saying we're going to pay you $100. We may pay you $200 at the end of the negotiation. But we're going to negotiate for the first time. ALS drug, withdrawn from the market after trial. So this is the other part of the Cures Act got passed. And the Cures Act got passed and said, we're going to accelerate drug approvals. We're going to rapidly accelerate drug approvals in this country. We're going to put them on the market before, so they still have to go do phase 1, 2, and 3 testing. But then the pharmaceutical companies are then supposed to spend the next 5 years actually doing tests and reporting it publicly, transparently, peer-reviewed journals to say, is this actually really the effect? Because the phase 1, 2, and 3 trials just say it's safe. They don't really know if it's effective, except you have to have time to say whether it's effective. So all of a sudden we have this big ALS trial, everyone wants to get on this drug, and we almost immediately withdraw it because it's very clear that it doesn't work. We just gone into decongestants. The scientists have been saying for the last 20 years that most decongestants don't work at all. They're all over the counter. We all spend a lot of money on them. And for the first time, there's some pushback at the FDA and said, we really need to pull this stuff off the market. It doesn't work. It's okay, it's over the counter, it's safe, but it doesn't work. People spend money on it, they expect something to work, it doesn't work. And finally, sort of with this is just a recent paper out of the UK looking at accelerated approvals of cancer drugs, right? 17 out of 23, 74% were withdrawn in the past 3 years because they don't work. Right? So this is one of these very hard. If you're a cancer patient and someone comes and says, you have one chance, you're going to go on this experimental drug, what are you going to say? Sign me up. Sign me up right now. But all of a sudden, you put this in, and all of a sudden, we're not certain that it works. And what we found is in the European Medicine Agency looked at this, very, very different results. They withdrew 2 from the market that were already withdrawn, part of what had been withdrawn in the United States. So then the question becomes, are European patients not doing as well? American patients not getting access? How does this work? And could we learn a little bit more between things? So let me just finish with back to Tammy Tangs. So Harvard life-saving study, they looked at 139 proposed regulations and said if we passed all of those regulations, we would spend $4.11 billion a year, and we would save an estimated 94,000 life years. But they looked at this and said, out of those same 139 interventions, if we actually focused on the cost-effective ones, as opposed to broad spectrum, same amount of money, same interventions, we'd have 211,000 life years saved, right? So here's one of these things, spending 182,000 every year for sickle cell screening, add 769 years collectively to children, black newborns, $236 for each year life year saved, 23 million on 253 million on heart transplants. We get about 1,600 extra years, 158,000 per life year saved. And remember, this is you have to go back because this is $1996, published in '97. Equipping just 3% of school buses, 1.6 million a year, save one child's life a year, $2.8 million. How many people are going to put safety belts in school buses? Right? It's a lot of money, and we have almost no effect. We spend $2.8 million a year on radionuclide emission control at phosphorus plants to protect. Remember, this is now EPA. $5.4 million a year, life years saved, cost. But if we took out of this, and we took $45,000 of that 2.8 million that we spend every year, and we put it into screening black newborn children for sickle cell disease, we would save 192 years, in the child, $45,000, we get another 192 collective years, and we'd have no effect, negligible to no effect on the risk to anyone working in a chemical plant. So the question is, what do we do? And as clinicians, are we actually thinking about this? At Lifelight, we think about this all the time. We are spending resources. We are stewards of precious healthcare resources. We just can't commit, and we spend money in a heartbeat, and we try to spend it wisely, but we have to understand that when we spend something, that's money that can't be spent somewhere else. And there's not a limitless supply of money, despite what this country thinks, right? There's not. All of you, the young people in the room, you're going to be paying for these things for a long time, right? So it behooves all of us to really start thinking about this. So back when we did the EMS at the Crossroads and the Institute of Medicine, did 3 big papers on pediatric emergency care, hospital emergency care, and EMS, the epigraph for EMS is, and we finished this with everything in Lifelight, knowing is not enough. We have to apply. We have to be willing to change in the face of evidence. We have to do new and different things, and we have to make sure that they work. And willing's not enough. We actually have to roll up our sleeves and do something. So with that, I'm happy to answer questions. I know I went a little bit long. Well, I think we're kind of on time. Anyone have a question? You can call me bonkers. You can just say, he's totally bonkers.
What's the difference between the baby and the 12-year-old?
The answer, healthcare economics, you save the baby every time. And there's a lot of science. There's been a lot of science that people said, 10-year-old, we'll save the 10-year-old. And that's like when they do surveys. But healthcare economics, life years saved, save the baby. It's really, it's a tough one. It's a tough one. But in survey after survey of people save the 10-year-old because they already have a life. They already have a life, right? They've already become something.
I thought it was having to do with the medicine, not the cost. So I may have been right or wrong.
Well, in healthcare economics, we're going to say, if that baby gets an extra 11 and a half, 11 3/4 years of life, and what's the value of that? What's the quality adjusted value of that? And that's why you've saved the baby. Given a choice, hard choice, right?
No, but I think what he's saying, and I had the same question, is that assumes that if you can only work on one of them or the other, right? Kind of like your first example
Right.
with the ambulance. You can only work on one or the other. You can only do it. So who's more likely to survive if they're both right at the edge of dying. So they're face down in the pool, they've been there the same amount of time. I would assume, but I don't know, that the 10-year-old would be more likely to survive. All things being equal, you can save one but not both. Then,
I
of
think
course-
all things being equal, probably the 3-month-old is the best chance of survival.
Really?
In drowning medicine, that's what we would, I don't know,
I would
Pete
have
might
thought the
disagree.
10-year-old. Okay, Doc, what do you think?
It's the ethical versus reality. Ethical, versus the, statistical reality of survivability, I guess, is a different discussion.
These are really hard choices. It's interesting. We are putting together the EMS became a subspecialty of emergency medicine. So now physicians can be board certified in EMS in addition to being board certified in emergency medicine. So we were putting together, it was about a 20-year to get to there, the colleges of medicine to do that. So there's 3 groups. One group's working on, here's the content knowledge. One group's working on the tests. One group working on the review course, and none of the groups are allowed to talk to each other. So I got recruited to help create the review course. So there were about 50 physicians, and I'm not a physician, there were 50 physicians down at ACEP in Texas. And we're sitting there one night, we kind of did the whole course for each other. And I'm sitting there one night, we're all sitting around kind of the campfire, and I said, out of all of you, what is the one patient that if you see that patient again, you're going to hang your stethoscope up? Say, I'm not going to do it again. I've done it, I'll do it right now, but then that's it, I'm done as a doctor. And all the young doctors were like, couldn't fathom the question. And all the gray-haired doctors are like, I know exactly the patient. I know exactly the patient of these hard, very hard, painful choices. And I will do everything in my medicine to make the best result for that patient. But the cost of that emotionally to the soul is just too high. And so there isn't, I don't think there's a perfect answer to any of these. And the ethical versus the real, I don't know, healthcare economics say the 3-month-old.
Or if you wanted to target households without smoke detectors, you could really increase basically 30% of children's availability to smoke detectors. But I think we could all agree that you could very easily regulate flammability of children's PJs with one rule, right, one law. But forcing people to have household smoke detectors, right, you can't actually convince them to do it, and they won't listen.
That's very astute. It's very astute because it's easier to write a regulation that you can force people to follow and becomes practical, right? Because the universe of who has to follow the regulation is a relatively small number of companies, and you can make them do it. So you're spot on to that because it's very hard to say, how do we know that there's smoke detectors in houses? And there's probably ways we could do it, but it is intrusive. It's like, why are you coming to my house? But we know in Maine, virtually, I would guess 100% of fatalities from fires in Maine, there's no smoke detector in the house. Right? It's pretty much universal, no working smoke detector in the house. So before the Blue Ribbon Commission, there was actually another piece in the legislature, the 2 sessions previous, and the legislature kind of at the last minute passed a No Surprises Act for medicine in Maine. And it was kind of last minute in the legislature. It was right in the middle of pandemic, 2020, and it was like came up at the last fleeting edges of the legislature. And they looked at it and said, we don't know how to do this. And the federal government said, we don't know how to do this with EMS. So then there was another group. They put a bunch of us together, and we actually gave the legislature, for the first time in legislative history, a unanimous report from the insurance companies and the EMS providers and the regulators. Gave them a unanimous report of here are the 9 things to do. So there needs to be more money in EMS. We need to spend it. But this is back to the pillars, we spend a lot of money in EMS on duplication. We spend a lot of money that we don't get the results that we set out to get. And that a lot of that goes back to, this is schools in Maine, this is all kinds of things in Maine because of home rule, that we're very strong for home rule in Maine. So I think the insurance companies that we need to, and now, Medicare is finally doing cost study to say, did we get it right back in 2002? And we know they didn't. And back in the 1997 Balanced Budget Act, which went, the fee schedule went into effect in 2002. So there needs to be more money. We need to spend it more wisely, and that means there needs to be some guardrails around, at one point when I was the chair of Maine EMS Board, we had 3 EMS services in Eastport, Maine. It was all Family Feud, and everyone's scrapping, and no one can survive, and we still have, unfortunately.
If you could fix it, what would you do?
What we said in that report, and I was the one that wrote a lot of the recommendations, we said that regionally, we're going to have to force some regionalization. We're going to have to incentivize it, and we're going to have to enforce some regionalization to make this happen. We are going to need to improve how we pay for community paramedicine, because we know that that's huge value. That when we did St. George, we started the first community paramedicine project. And our premise was, so the average person in Maine, when they can't cope, ends up in a nursing home, and in 13 months they spend their life savings, and after that they're a Medicaid beneficiary for the rest of their life. So the cost of that, then in those, back in that was about $12,000 to $13,000 a year for Medicaid. So we could say if we could keep 9 people in their homes in St. George safely for 9 more months of their life, we could pay for full-time paramedics. So these become these other sides of trade-offs that we have to really start thinking about, and that gets into regulation on the insurance side that they're not happy about. So it is going to be a combination. It's going to be incremental, but regionalization, more smart money, not just sort of here's some money because you're going to come back next year and you're still going to be in the same boat.
So one of the things I think about is regionalization. I get your point about having 3 EMS providers in one town isn't smart, but we don't have enough places where the citizenry are paying for EMS coverage the same way they pay for fire or police. And in my town, we support the EMS providers providing service with about $400,000 of subsidy from the taxpayers to make up for the what they can't get through Medicare or Medicaid or whatever, or private insurance.
Reimbursement.
So I guess the question is like, regionalization is difficult. You got rural areas where it's 45 minutes to 60 minutes of response time for ground, right? So you can't.
Go to Franklin County.
And
Go to Franklin County and they figured it out.
It's the same discussion that happened with EMS, not EMS, fire. I mean, it's a 4 to 5 minute response time. Otherwise, the firefighters are cellar savers, right? So what really don't you have to force something on the towns to start paying for the service?
I think that, what's interesting is in Tammy Tang's work, she immediately got a lot of criticism saying, you're just pushing regulation. And I'm not pushing regulation. I'm pushing people trying to understand cost effectiveness. And you might do this because it's the right, smart thing to do. And over time, it's going to make your budget better, right? So I think that's a piece that we sort of need to get to. But you can go to Franklin County. It's not perfect, but they pretty much figured it out, right? And this was, it's a healthcare-based ambulance system, multiple bases, some of the most rural areas of Maine, and they cost-effectively do it. It's transparent of what the subsidies to the communities are every year, and there's a conversation every year about what the required subsidy. If you look in the highest value EMS systems worldwide, it's public utility. They're all public utility. So it's a regulated utility worldwide, and that's what What they're going to do in Newfoundland, which they'd already done, you know, the provinces are just like the states here, they'd already done in Nova Scotia, Prince Edward Island, New Brunswick, is they're closing down all the private ambulance services. It's all going to be healthcare system based, and it's going to be a regulated utility. So it's not government run. It's a contract. It's a renewable contract for 10 years to manage the system. It's a contested contract. So that's, you know, to get with a lot of pieces written in of how you're going to calculate value, how we're going to, you know, what are the requirements for value and quality. And I think that that's where you sort of get to if you want the best. There's 19,000 EMS systems in the United States. You've seen one EMS system, you've seen one EMS system. It's a very huge variation. But if we look at the corporate configuration and we look at how we pay for EMS, there's about 55 different combinations of how that gets done in the US today. Any other questions?
One last question.
One in the back. Yeah. We'll finish up because so this is, you're very kind to.
Just going back onto the scenario with the two kids, if both of them were around the same age, how do you determine who to save based on value?
Whoa, how do you turn to say? I just get to make up thought experiments. I don't have to answer them. I just make up the thought experiments. I think it's, that's really hard, and probably someone said it's going to be the one you can reach the fastest. You know, I think in reality, you know, you would get both kids out of the water as fast as you possibly could, and then see what happens. And I had a friend, you know, when we used to work for Outward Bound, their biggest risk wasn't drowning or falling off of cliffs. Their biggest risk was getting hit by lightning. And that's their biggest risk nationwide was people getting hit by lightning. And I had one of my good friends, Bob Flight, and he had you know, they were down in Florida, and they got massive lightning strike and 13 kids not breathing. And he just went from kid to kid and got them all breathing. And everyone was fine at the end of it. So I think the reality is probably you would pull them both, and here's a breath, here's a breath, here's a breath, here's a breath. You try to resuscitate. But it's a good thought question about scarcity of resources.
Well, I said Tom was a good storyteller, so we'll end on that story. Thank you, Tom.
Thank you all.